Now, so far, what's our knowledge? We estimate left ventricular ejection fraction by either human or automated computer-based measurements of end diastolic and end systolic volumes through the tracing of endocardial borders, followed by model-based calculation. Now, what's new here is that this EchoNet dynamic software, it's a deep learning algorithm that was trained on echocardiogram videos to assess LVEF on a beat-to-beat basis. It mimics the human eye by estimating left ventricular ejection fraction from the degrees of ventricular expansion and contraction, myocardial thickening, and motion of the mitral annular plane. It does not depend on tracking of the endocardial borders, and it integrates the best possible view from plaques, apical 4-chamber and apical 2-chamber views. Now, basically, this EchoNet dynamic algorithm that incorporates machine learning by using convoluted neural networks, popularly known as CNN. It applies the semantic segmentation of LV and predicts ejection fraction by looking at the subsample clicks. It assesses multiple cardiac cycles to minimize error and produce consistent results. Now, back in 2020, Young et al. From Stanford University had published EchoNet dynamic database, which included almost 10,000 patients, their echocardiogram videos and measurements tracing, which is all available online. Now, it has been seen that by estimating echo by artificial intelligence, the mean absolute error is only 4 to 6%. So, there's a lot of difference of evaluation of left ventricular ejection fraction by humans and by artificial intelligence. Basically, humans, it depends on the level of expertise, and there is significant intra-observer and inter-observer or inter-institutional variability. Now, again, estimation of the EF may be problematic in humans where there is poor image quality. And basically, we depend on biplane Simpson LVEF, which is the popular volumetric assumptions by doing endocardial tracing. Now, artificial intelligence, this is a machine learning algorithm, and this machine can guide also the transducer position to detect the best possible image and orientation. And as I said previously, these machine learning algorithms are not based on endocardial tracing. They use beat-to-beat left ventricular ejection fraction calculations in multiple views. So this was published way back in Nature, but still then we did not have any blinded randomized study. So here comes the importance of EchoNet randomized control trial. It's a blinded randomized control trial of the sonographer versus the artificial intelligence assessment of cardiac function. The lead author is David Young. So this is the standard clinical workflow. The sonographer does the scan, and then the sonographer has the initial assessment, and finally it's been checked by the cardiologist report. Now, artificial intelligence predicts left ventricular ejection fraction like the sonographer's initial assessment, and thus perfectly fits into this clinical model. Now, the trial design was that there was almost total of 3,495 patients randomized. They have been previously scanned by a sonographer, and they have been randomized in 1:1 ratio, either by estimation by artificial intelligence or by the sonographer initial assessment. And finally, they are being judged by a cardiologist who is blinded. He does not know whether it's been done by artificial intelligence or by the sonographer. And the primary outcome of this study was that whether the cardiologist is changing the ejection fraction results by more than 5%. Now, if he is changing the results by more than 5%, it's been judged as a positive result. Now, this is a single center EchoNet randomized control trial, and it involved 25 sonographers with a mean 14 years of experience, and it involved 10 cardiologists with a mean 12 years of experience. So the people were a lot experienced who are conducting this study. Now, apart from this primary outcome, the trial also had certain secondary outcomes. One of the important secondary outcomes was that the cardiologist report should collaborate with the previous historical cardiologist report. So that is one secondary outcome. And other secondary outcome parameters were time taken to generate the report, whether who is faster, whether the artificial intelligence is faster or the sonographer is faster, and whether the cardiologist could distinguish the reports, whether they were generated by artificial intelligence or by the sonographer. So it also tested whether the cardiologists were really blinded or not. So this is the trial design. I've talked about the primary outcomes, looking for the change in the EF, and looking for the secondary outcomes. That's basically the time, assessment by the previous historical cardiologist report, and also whether the cardiologist was properly blinded or not. So this is the flow chart we have already gone through, and we have got a mixed bag of population with the mean age was around 67 years, 57% were male, and a lot of the patients had a lot of comorbidities. You can see hypertension, diabetes, coronary artery disease, CKD, atrial fibrillation, whereas there is beat-to-beat variability in the rhythm and prior stroke. Now these are the trial results. Now you see, when there is the artificial intelligence arm, there is 16.8% modification done by the cardiologist report. But when it is by the sonographer, there is 27.2% modification of the ejection fraction done by the cardiologist. So the p-value is pretty significant. In fact, the p-value reaches the superiority range. Looking at the secondary outcomes, there is also historical changes as measured by the cardiologist from the previous cardiologist report. So around 50% of the reports got changed. And when the sonographer did the assessment, that arm, almost 54% reports got changed. So it implies that a lot of reports generated previously were erroneous. Then again, if you look at the time taken, now when it is done by the artificial intelligence arm, it took only 54 seconds for the cardiologist to generate the report. Whereas for the sonographer arm, it took 64 seconds. So there is a significant difference in the time also. Using artificial intelligence, generation of the LVEF report takes faster. And so majority of the secondary outcome trials were in the superiority range. And the most important, the blinding part, the cardiology could not distinguish whether the report was generated by artificial intelligence or the sonographer. You see 43% of cases he was unsure, and 24% of the cases he made an incorrect diagnosis whether it was done by artificial intelligence or the sonographer. So the blinding was pretty good. So these are the trial results which I already discussed, and the results were consistent along all the subgroup analyses. Depends on the racial differences, sex difference, or the image quality, whether the location was indoor or outpatient. So, but the limitations of the trial was that this is only a single center trial, but it is an eye-opening trial and it's a path-breaking trial. So further work needs to be done to assess its long-term impact. The strengths of the trial was, this was a very good trial, properly randomized with a lot of external validation. The EchoNet dynamic data is available online and it's available since 2020. So the randomization was done with an active comparator, that is the sonographer. And the blinding was quite successful, and this is the largest study of clinical retest of left ventricular ejection fraction. So ladies and gentlemen, to conclude, for adult patients undergoing echocardiographic quantification of the cardiac function, initial assessment of left ventricular ejection fraction by AI was non-inferior, and in fact it was superior to the initial sonographer assessment. And after blinded review of the initial LVEF assessment, cardiologists were less likely to substantially change their final report when it was done by the initial AI than it was done by the sonographer. Now, AI-guided assessment took less time for cardiologists to overread and was more consistent with historical cardiologist assessment, which is the test-retest precision. The other important parts of this trial was, this was the first randomized trial of an artificial intelligence algorithm in echocardiography. Now, artificial intelligence algorithm can be integrated into the usual clinical workflow in a blinded fashion. It is just replacing the sonographer's assessment. The sonographer is doing the echo and the cardiologist is giving the report. But in between, there was the sonographer's assessment, which is being replaced by artificial intelligence. Artificial intelligence is not doing the echo itself, neither it is not replacing the cardiologist's job. AI algorithm could be very effective at not only improving the quality of echo reading output, but also increasing the efficiencies in time and effort spent by the sonographers and cardiologists by simplifying other tedious but important tasks. So embedding AI into clinical workflows could potentially provide more precise and consistent evaluations, thereby enabling earlier detection of clinical deterioration or response to treatment. It is very sensitive. It can pick up subtle changes in the LVEF. So AI algorithms can train general internists in estimating LVEF at par with experts and thus provide useful and reliable clinical information in emergent and low resource settings. I thank you for your time and attention.